Free audio post-production by alphonic.com.
I'd like to begin this podcast by acknowledging the Turrbal and the Yugara people, who are the traditional custodians of the land on which we meet today to record this podcast. I also would like to pay my respects to their elders past, present, and emerging. Hello, Academy Associates. Thanks for choosing to listen to the BarbellJack Academy podcast, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access, click on the link in the show notes. To keep up to date, join our Academy mailing list where you'll receive exclusive content, discounts on webinars, and more. Link to join us is also in the show notes.
We're going to be talking about, Caitlin just corrected me, I said glute med tendinopathy. It is greater trochanteric pain syndrome, or lateral hip pain, we'll call it. So we're going to be talking about this. I think from my practice, it's something I've seen a lot of in the last few years. We can probably go on about the etiology, but I'm sure you're aware, more commonly in females, usually of that sort of 40 plus age bracket. But today we're going to have a chat about sort of some assessments. I wanted to get stuck into some behaviour modifications as well, and then talking a little bit about sort of exercise progressions. And I think the big thing here as well is what should we be doing with it? So what are some safe exercises that aren't going to annoy anything? So let's kick things off. How would GTPS present to you, Caitlin?
So in my clinic, when I have someone who comes in with a presentation of lateral hip pain, I'm really trying to understand what their aggravating factors are. So we know with greater trochanteric pain syndrome, they're often reporting pain with after a period of reduced movement. So they might report that they've been walking around and then they sit for a little while and they go to stand up, and the first couple of steps are uncomfortable. They'll report pain with increased loading, so might be reporting pain if they walk for longer than they would normally expect, or they're saying that their overall loading function is reduced. A really classic one is they're unable to sleep on the affected side. So the factors that we're looking at with greater trochanteric pain syndrome is we're understanding that it affects multiple structures around the lateral aspect of the hip. That's why they've now, rather than calling it trochanteric bursitis or glute med tendinopathy, we know all those structures are affected. So we think about, is there compression around that lateral aspect of the hip that's contributing to it? Is there stretch? So often these are the clients that may present saying pigeon pose always feels really uncomfortable, or I'm trying to stretch it, and it feels like it's getting worse from there. And then the other aspect is that loading. So they're often reporting pain with stairs, pain with single leg based activities.
Yep. Excellent. And sort of, as we know, in that single leg position, the demands on your glute med or that lateral stabilizers is a lot more.
Mm-hmm.
In terms of sort of common causes, I think in my experience, a lot of it comes from, like a lot of it, tendon-based issues, is an acute increase in load. I think a really common one that I see, especially in that population that we spoke about before, is actually going away on holidays and doing a lot of walking or climbing a lot of stairs where there's a lot of single leg load, or potentially starting new exercise programs, running, doing a lot of lunging and things like that. Is there any other sort of common causes that you see in your experience that can lead to this?
School holidays, grandparents looking after their young grandchildren because they're not used to the loading and the rocking side to side. So we know that that can have a fair bit of forces going through there as well. So that's a little one that I've seen.
Excellent. So we'll
a bit more as well.
School holidays.
No, we won't cancel school holidays.
Excellent. So I think in that early intervention, we've spoken a lot in our podcast about sort of getting that good history, that understanding of where their health's at and things like that. Moving past that, I sort of wanted to touch on some education, some early education that you provide with these clients, because it can be pretty often, these flare-ups can be quite sore and they can be pretty debilitating as well, because it is a major joint of the body that takes a lot of load. I think from my opinion, a couple of really important behavior modifications are avoiding those compressive positions. So I think the big two that I see, or three I'm going to call them, is probably sitting with your legs crossed, as we are now, sitting in a deep chair as well, and also looking at someone's standing posture. Are they leaning across? Do they use a walking aid? Do they lean on one side where they're pushing the hip into some sort of adduction? So I think we find with the lateral hip, we get most compression in flexion and adduction. So basically those two things combined. What are some of the other big behavioral modifications you'd be discussing with your clients early phase?
Sleeping. So really encouraging not to sleep on that side. And for those people that like to sleep with their legs crossed over, getting them to sleep with a couple of pillows so that they're not going into that flexion adduction position. And another one is how they move. So I often try to educate people about train track positions. So you can educate people about the positions, when you're sitting. Don't sit in the deep chairs, don't cross your legs, but also look at the mechanics of how they get up out of sitting. So if they're going into a knee-locked position when they go to stand up, that's going to be putting compressive forces through there. If they're going upstairs and they're often crossing one leg over the other, or when they're walking, for some reason they go into like a tandem stance style gait, we want to educate them to try not to do that as well. So there's some factors that I really get other people to consider.
Excellent. I purposely left the sleeping one out of mine because I wanted to ask you, this is that advice we give, and I think, the pillows between the knees and avoid sleeping on that side. I think for a lot of people, as they sleep, they don't really have much control of the position they're in. If that was really problematic, is there any additional things that you would suggest to modify? Would it be sort of the surface on which they're laying on? I know I've heard of people actually tying a pillow between their knees in case it comes out and things like that. Is there any further modification in that sleeping side of things that you think is necessary?
Not really, because what you're looking for is, can someone get to sleep, is kind of the most important thing with sleeping. So we know sleep affects pain. So we want to improve an individual's sleep quality. So if someone's saying, I can't get to sleep because of the position, like laying on that side, that's my favorite side, well, we try and find different positions that we can get them to sleep in. I can't say that I've ever told someone to tie a pillow between their knees. All I simply tell them is, if you wake up and you're on that side, roll over to the other side, find where you've thrown the pillow and put it back in.
Yep.
Is kind of the strategy as I go with it, because I find then clients get too worried about, I've got to sleep this way, they've told me to sleep this way. Whereas if they can sleep through most of the night and they wake up at 4 o'clock in the morning on that side and then roll over, that's fine.
Yep.
From my aspect of it. So I don't try and go too far down. It's more just about educating the why. Because if someone can understand why sleeping on that side's aggravating, they then understand why it feels uncomfortable when they've woken up and they're on that side, and then they can reason through it and modify.
Yep. Excellent. So moving on to some sort of assessment tools. Again, similar to the rotator cuff, it's quite broad, and we've spoken about sort of how it presents and how it can show, and we're going to go to a movement screen, I assume, most likely looking at some sort of strength through the lateral hip, the pelvic region as well, the lower limbs as well. Is there a reason we're getting so much force and pressure into the side of the hip? What are some common assessments that you like to use?
So common assessments, I like to rule out that it's not from the lumbar spine. So we know the glutes are innervated by L5. So we want to make sure that someone isn't having a form of radiculopathy that's presenting as lateral hip pain, which is one of our differentials that we have a think about. So then when we're having a look specifically going what's happening around the hip, we want to understand, is there a movement restriction at the hip? So does someone have, in that age group, do they potentially have a cam or pincer morphology that's contributing to how they're loading around the hip? Is it someone that has, like we've already mentioned, the strength changes through there? So having a look at, well, where's the actual deficit? So in our clinical assessments, we can't isolate the glute med muscle. So I think it's really important when we're doing our assessments, we're using the right terminology. So we're screening hip abduction, we're screening hip adduction, we're screening hip extension, and we're having a look at deficits with regards to that movement patterning, rather than specifically saying this is the glute med, this is the glute max, that we're screening from that aspect of it. Because part of the glute max is actually a hip abductor as well. So we're having a look at those movements as a whole and going, where's the deficit side to side? A key factor for it is pain. So is this pain provocating for the individual? And that then leads you down that clinical pathway that this is GTPS.
Yeah, excellent. I think some of the common stuff that I like to use, I think, again, it goes back to maybe what's caused it and how they're presenting, using our stair climbing as a cause, actually assessing, okay, how's their squat? What's their bilateral movement like? Looking at some sort of stairs ascent and descent, I think is really important. So looking at from both the top of the stairs and the bottom of the stairs, some sort of single leg stability. So looking at this single leg stance, not just seeing what their balance is like, but okay, what's their pelvic position? What's their knee position? Is there anything further that you'd add to that in your movement screen?
Yep. I have a look at lunges, but depending on age category, I'm not going to get an 80-year-old to lunge, but I might get them to do a step up. So similar to your stairs, I will often have a look at, as part of my overall screening, a squat, a single leg squat, if appropriate for the age group, or a single leg sit to stand. If they're not tolerating that, having a look at split stance, sit to stand, because I want to understand what is their current activity level that is not provocating. So if someone can sit to stand and it's not pain provocating, but they can't do a single leg sit to stand, I want to see at what point can they actually tolerate the load appropriately, because that helps me build my program from there. I have a look at a lunge. I'll have a look at bridges, potentially single leg bridge if appropriate, or a split stance bridge. Depending on the population as well, I might look at a side plank, because I know how that loads up the lateral structures, but also includes our trunk musculature to see whether that's a bit of a contributing factor as well.
Yep, excellent. No, I think they're all great, and I guess in terms of choosing those assessments, looking at, okay, what can they actually do at the moment versus what they need to be able to do as well. So make sure you're considering that when you choose your assessments, because obviously you want to go back to them and check them later to make sure they aren't painful. Perfect.
Hello again. Thanks for taking the time to listen to our podcast. Another shout out to a sponsor that we have, the BarbellJack, where you can master your lifts to save time, energy, and lift like a pro. The BarbellJack isn't just any gym gadget though. It's your new best mate, designed to ensure a safe posture when changing weight plates. This is a must-have in your clinic. Embrace the power of professional lifting techniques and hit your personal records with ease. Use the code BODYTRACK to receive 10% off your order. Now back to the podcast.
In terms of assessing strength measures, do you use any like handheld dynamometry in your practice at all?
I do, depending on the patient that's presenting with it, and depending on their pain levels as well.
Excellent. Would you be looking at assessing some sort of abduction strength in this population?
Yes.
Yep. Excellent.
Again, based on pain levels.
Yep. So I think for that, we probably wouldn't go straight into a long lever hip abduction side lying if it produced pain. So looking at something, maybe a short lever or a bed knee or something like that from that position. Moving into that early phase intervention again, let's say the pain levels are a little bit on the higher side. What are your sort of early interventions in terms of exercise?
So if someone's irritable I want to understand what's primarily contributing to the irritability. So again, I reflect on a lovely grandmother I had who's in her mid-70s, and this was just something that was progressively getting worse and worse. She's now noticing it every time she goes to stand up. So the first thing we looked at was going, let's drop load, because she'd increased her walking on the school holidays with it. And then let's address your movement patterns that are provocating. So she had stairs at home, so educating her how to go upstairs. So rather than going up alternating stepping, because we couldn't modify that, how do we reduce that load with her going up and going down the stairs? Having a look at how she gets out of a chair and going, okay, can you actually get up and maintain hip and knee alignment without loading? No. Okay, you need to push up. So you need to actually support yourself in getting up out of the chair. So really looking at the strategies on how we can reduce that overall pain levels, and then that gives us a parameter build up from there. Compared to someone who is not as irritable, we then might take more of a strength focus, going, okay, you only get your onset of your symptoms at the end of a 7-kilometer run, or you get the onset of your symptoms the following day after a run. What do we need to modify with your movement mechanics? Where are your strength deficits that we need to start and change with? And they might be the kind of person that we do weighted squats because they can tolerate that double leg loading, and then do a split stance, sit to stand, where they're actually focusing on that movement mechanics without overloading.
Excellent. No, that all makes sense. And I think especially in terms of the walking, getting a good understanding of, okay, is there a lot of hills involved, downhill, uphill, uneven surfaces? Usually, like with a lot of running things that we spoke about, increasing cadence or decreasing stride length is a great pain modifier in this population as well. And then potentially if walking is quite problematic, it's someone who's quite active, looking at some deloaded sort of forms of exercise, like the bike or maybe the rower as some sort of alternative. In terms of specific hip abduction or abduction strength exercises, do you have a bit of a set of some go-to sort of strengthening exercises, and what do they look like?
Absolutely. So we know with all the evidence that's coming out with the research, and a lot of it's actually based out of UQ, which is really awesome, is that the optimal loading patterns for the glute and our hip abductors is closed chain. So clams, your good old Jane Fondas, your side-lying leg lifts actually aren't loading the muscle appropriately. So my go-tos for this population are bridges, sit to stands, but modifying them to the level that they need to be. So whether they're split stance, whether they're single leg. I then progress them by adding weight, not bands. So a lot of people think, oh, if I put bands on, I have to work harder. Unless someone's really, really aware of their movement patterning, often what they'll load is at the anterior lateral hip. So we're going to see more VAS-lat, more TFL loading, which is a compensatory pattern, especially with this population. So the biggest thing for me, and again, this is a big change in my practice over the past 15 years, is I don't generally add bands. I might sometimes with the standing, like your crab walking or your soldier walking, but more often than not, I add load, because that's where we're seeing the changes, especially when we're thinking about what is involved in muscle hypertrophy. We know that we need to see about 40% of that MVIC. That comes with load.
Yeah, excellent. No, that all makes sense. I think a big part of my practice is using some of that resisted abduction through bands. In those early phase stuff, is there a place for isometrics with bands in more of that deloaded position? Because I do find with a lot of the closed chain exercises, they could be pain provocating, like your single leg bridges. Sit to stands, probably not so much, but to really isolate those muscles. Do you find there's a space for that?
Not with a TheraBand.
Yeah.
So a TheraBand is going to have, it's not about the resistance, but because it's not a firm structure, you can actually end up with a vibrational force that goes through the tendon that can be provocating. So if you're going to do any isometrics, it needs to be with a seatbelt, or it needs to be with a belt. So something that doesn't allow for that vibrational movement. With regards to in a side-lying clam, no. if I'm going to get them to do anything, it's going to be in sitting with it, or it's going to be in a crook lie position where they're actually resisting out against the band, because they need that feedback with the heel on the ground with regards to it. Then from a banded perspective, if I'm thinking open chain, I really don't give someone an open chain banded exercise unless it's specific for an activity that they need to do. And there's only a very niche population that will generally be.
Yep. Excellent. No, that all makes sense. In terms of progression and moving towards, like, obviously our clients are going to have our functional goals and what they want to achieve pain-free, and we're starting to see improvements in that. Is there sort of like an exercise level or challenge for the hip abductors that you want to get them to with your loading patterns?
Step ups is probably a really big one for me. Maybe single leg sit to stands to see, again, if it's appropriate for that population. But again, it comes down to what does that person need to get back to. So if I'm looking at someone, they just want to be able to walk up the stairs pain-free 10 times a day, well, how many step-ups can they do under load? That will give me that indicator from there. If I've got someone that's a runner, well, what's their running tolerance like? Are they progressively increasing their distance without aggravation or irritation, especially the following day?
Excellent. And we've sort of touched on this previously in other sort of tendon-related podcasts or topics, but progression criteria. So I find this can be a bit of a funky one because presentations can be very up and down. It's not a linear approach. Let's say you've chosen your exercises and what you want to do with them. How long should you stick with those before moving to the next level?
So mine's based on pain and function associated with it. So if we use the traffic light system with tendinopathies, we're thinking, okay, if it's generally about a 2 out of 10 pain during the exercise, settles immediately after, you don't have any response 24 hours afterwards, that's one that you might be okay with increasing a little bit more through there. If you've got someone that's got about a 2 to 3 out of pain during, and then they've got pain 24 hours afterwards, something about that exercise is aggravating, whether it's they've had that 2 out of 10 pain and they've done too many repetitions, so they haven't been aware of them, they've lost control associated with that. So mine is based on pain, quality of movement, and also potentially reported fatigue, depending on the exercise I'm doing.
Excellent. No, that all makes sense. And in terms of I guess modifying exercise and what we can do with the lower body in those early phases, would your general advice be to let's say a client that I've had in the past, a 40-year-old mum who attends FitStop and does sessions there. So general advice would be avoiding, single leg plyos, avoiding your lunges or heavy repeat lunges and things like that. I generally find that more posterior chain loaded exercises like your RDLs, hip hinges are generally going to be a lot more tolerable. Any other advice you'd add on top of that in terms of more those exercise modifications?
So my exercise modifications that I tell a lot of my patients about is we can generally load double leg quite comfortably. So at times they might find that their single leg or their split stance isn't improving. And what we simply may need to do is just continue to load double leg until they've got an overall global improved capacity to then transition to more of that split single leg loading. So again, a lot of the same things, limit pilo. If they're doing lunges, get them to do static rather than alternating. Get them to do lunges in a slightly more trunk-leaned position, so you've got more bias through the posterior chain, so a little bit more of your hip extension bias as well.
Yep,
through
excellent.
there. So yeah, much the same.
And would you be avoiding deep squatting if you were doing bilateral work?
I go for patient comfort. I probably generally would do more sit to stand because I'm trying to promote movement mechanics as well, rather than a deep squat. So deep squatting would be something that I would progress to once they're quite comfortable with doing a double leg move, transition to split stance or single leg loaded activities.
Yep. Excellent. All right. That sounds good. Did you have any other points you wanted to discuss on GTPS?
Probably, again, a key takeaway with GTPS is have a look at the whole kinetic chain. Have a look at the trunk. Have a look at the knee. Have a look at the ankle. So again, mutual client that we both have is a lot of his lateral hip pain is secondary to altered knee mechanics. So if we don't address that, it's going to be really hard to address his lateral hip pain.
Yeah,
with it.
Excellent. No, I definitely second that advice and looking holistic. I think like what you mentioned earlier, looking at some sort of lateral chain strength, whether it be sort of, your oblique strength and that's really important in sort of connecting everything together as opposed to diving straight into the glute, which is generally around the side of the pain.
Yeah. And again, rule of thumb, if you are working with someone and they're not improving, refer on, just again to get a different set of eyes over it to see, well, what else could this be? What else is potentially a contributing factor to this presentation with it?
Excellent. All right. That'll wrap us up. Thank you.
No worries.
Thanks for listening. We hope you enjoyed this podcast. So remember to share, like, or follow to keep updated with all our podcasts and educational resources.
Free audio post-production by alphonic.com.